This is a very, very helpful educational activity, and I appreciate very much the effort and time that you put for producing these beautiful lectures and educational material. I am not going to be talking too much. I'm going to pass the microphone to my dear colleague, Dr. Christina Sadowsky. But before I pass the microphone, I need to say that, Sarah, you have what I always like from every person that I encountered. You have a very high vitamin P. You know what that means? Vitamin P is being positive, and you have a high resilience, and that is fantastic. And I think that your example is the best example that is giving us the best hope that everything that we do for our patient with acute flaccid myelitis should focus in keeping everybody in that spirit of positivity. And I think that the fact that you are going to Davidson is fantastic, because
Thank you.
for the parents and for the families, this is a team effort. This is
We lost you. Okay, he froze. Well, that's okay, because I'll take over. So Sarah Todd, thank you so very much for your wonderful, positive presentation. And I just wanted to...
And I appreciate very much that effort. So Christina, I will pass the microphone to you.
Yeah, so I was about to ask Sarah Todd, well, I noted that actually your disability transformed you into a very able individual,
Yes.
More than many of the individuals without a physical disability. And you did mention that you were very aware of the fact that things are happening to you in a different way at the age of 9.
Mm-hmm.
Was that something innate, or it was induced by the fact that you were in the context of hospitals and therapy and medical sessions as opposed to school?
Yeah, when I was in the hospital, I wasn't really like thinking about how my life was completely changing at that point, because I was just kind of like, well, I'm kind of going along with what's happening and it'll all get better. And then obviously once I left the hospital and then got home, that's when it became a little harder, because I thought, you know, I'm at home, my life should be how it was. And I didn't go back to school for 3rd grade. I had my teacher come to my house. So I missed out on school because I was trying to focus on therapy. And then when I went to Baltimore and I had to start traveling for medical treatment, it really was like, I started to realize how much of a big deal it was. That's really what I mean. I wasn't at school with my friends and I was focusing on therapy, and I wasn't just doing what most 9-year-olds do. And I mostly just kind of wanted to get back to being a kid. And I was honestly I just learned to accept that I had a disability, and I just kind of wanted to move on and just relearn how to live my life that way.
That is amazing. Thank you for sharing with us, because the truth is all of us healthcare professionals over here are hoping that we can teach our patients that. And I don't think we're always successful, but thank you.
Thank you.
It's a great story that you shared with us. Dr. Olasek-Joyce, you've been dealing with children with AFM and paralysis for a significant amount of time. What is that one long-term complication that is giving you the most amount of troubles when it comes to addressing it? You can say 3 if you want to, but
well, probably for us, and I had talked about in my talk that the medical versus the functional long-term complications vary so much from center to center, patient to patient. And in in our center, with my patient population, I actually haven't seen too many of the long-term medical complications. Many of my children actually have had resolution of their bowel, bladder, cranial nerve dysfunction. So really, I think the most challenging for me is trying to figure out how to best maximize functional potential, whether the case I presented with RH and watching him walk so expertly with this significant paralysis of his lower limb. And just sometimes I feel frustrated with how can I help him better? How can I help him be better? And of course, you saw that I failed when I tried the toe off AFO in clinic, but then that really helped me think, okay, what else can I do now? That's not working. Let's go to something else. So I think just thinking about how we can make these kids the best they can be, I think that's just the constant focus.
So the concept of individualized and personalized medicine applies very well to these children.
Yeah.
Thank you. Michelle and Kofi.
Yeah.
You told us a little bit about your plan and how you managed to do activity-based rehabilitation for the diaphragm. Do you have any prognostic factors? When you first admit a child on a ventilator, do you know what that child's future is going to be when it comes to respiratory function?
No. I think that we look at, as we get to know them, right, after the kind of first few weeks they're here, we see what else they're going on. What are they doing in therapy? What's their head control like? What's their swallow like? And that gives us a little information. But really, the best test or the best prognosticator is what the child actually does. So, this kind of came up for us in the past week where we had a child who had been seen elsewhere and had some nerve studies that showed that his diaphragm shouldn't be working at all. And yet he's breathing over the vent. And so obviously those kinds of nerve studies are really important. Like when you guys get on later in the July 10th session and we talk about nerve transfer surgeries and things, they're very important there. But for me, as I sort of explained in this case to the child's mom, I'm less concerned with what that nerve study shows and more with what the child shows me. So if I have a child who, we take him off the vent and, give him a minute or two off the vent and we see that he's maintaining some good tidal volumes, he's maintaining good numbers, that to me is a better prognosticator than the nerve study in isolation, right? Without looking at the actual patient's clinical presentation. We do sometimes do the diaphragm ultrasounds. Those can be useful, sort of popping the kid off the vent for a while and seeing, kind of gives you a little better picture of what they're doing. But really, my personal philosophy is I'm going to let every kid kind of do as much as they can do as far as they show me they can do it, as opposed to kind of making assumptions at the beginning. I don't know if that's the answer you wanted.
Hey, whatever answer I get, I think that is a very good answer, that the actual function is much better than testing because testing has its limitations. I have another question for you, but I'm going to hold because there are some other questions in the chat area and we're behind a bit.
Yes.
I'm going to go to Courtney only because this is the order of the presentation. And I'm going to ask you, how do you balance 3 to 5 hours of therapy with joyful living in these children?
It definitely could be a challenge at times. I mean, they're kids. They don't want to do therapy all the time. So we try to just make it as fun as possible. As you can see in a lot of my pictures and videos, we incorporate games, we incorporate different toys, ride on cars. iPads are a common thing in our gym. So just trying to make it as fun as possible. We also bring in extra staff as much as needed, or other patients, so to see them kind of play with each other, or to have our child life or therapeutic rec or behavioral psychology come in as well, just to up kind of that play factor, and then sneak in the therapy in the middle of all of that play.
And what do you tell parents to do after they are discharged?
It's a lot. I actually, in listening to the presentations a few weeks ago, listening to Rachel Scott say everyone says it's a marathon, not a sprint, is definitely something that I have told plenty of people, but it's longer than that. And I think you need to remember, similar to what Sarah Todd said, you still need to live a regular life. You want to get back to your activities. You want to do what's fun for a kid. So finding that balance, it's very challenging. But finding that balance between just sneaking in those therapeutic things in your regular life, but not having that therapy be your number one goal, and you're always only doing therapy and never doing play or fun activities like any typical child would do.
So actually supporting the personal passions and incorporating therapy into that personal passion and personal goals.
Yeah.
I'm going to move to Dr. Jane Mahim. There is one question from Rachel Scott. She is asking, and actually I was planning on asking you that. When do you decide to start bisphosphonate therapy? Are we preventing or are we reacting to bone loss?
Right. So I would say, it is something, in this session, we talked about kind of individualizing the treatment. And that applies also to bisphosphonate therapies. Usually, what we have been doing is responding to the presence of finding indications of bone loss. These indications don't always have to be a bone density scan, but definitely other clinical factors like fractures. Losing or having a very high calcium level, the development of kidney stones that are calcium based. When it comes to the treatment, I wish that something I did not discuss was that with every medication that we could potentially give, there's also the risk of. So I try to provide this treatment in response to findings, rather than as a preventative.
Okay, well, thank you. I have, again, other questions, but because we're short on time, there is one more question here that, Carlos, maybe you want to take. It has to do with the enterovirus D68 and its relationship with Guillain-Barré, transverse myelitis, acute motor neuropathy, and so forth. And if there is a correlation with the blood.
Yeah, actually, the answer is quite simple. We don't know. On enterovirus D68, it's very likely that may be a triggering factor for Guillain-Barré, but we don't have too much data on that. Guillain-Barré is frequently triggered by viruses like Zika, influenza. It may be triggered by other infectious disorders like Campylobacter jejuni. There is a bacterial gastrointestinal infection. We don't have too much data on enterovirus D68. And again, we don't know too much about the blood group susceptibility in AFM. We will learn that probably later after we compile more data, and probably with the NIH natural history study, we are going to learn more about that. So we are exactly at 3 o'clock, but I want to take the opportunity to ask everybody, and the answer should be very brief. What is your dream for AFM from your work, and what do you like to accomplish? So Joyce, that's for you first.
Oh boy. I think Sarah Todd said it so well when she said we need to focus on getting kids back to activities they enjoy. And I think no matter what kind of recovery we achieve in these patients, I think it's so important to find what motivates these kids and just get them back into life, and whether it's dancing or all the great things that Sarah's doing, just having them have a good quality of life.
Great. Michelle?
Yeah, absolutely. I think that it's important for us not to kind of think narrowly about what the options might be. So, for example, we're talking about respiratory stuff. We've had some talks with our pulmonary folks about, external ventilators, and we're obviously looking at different kinds of pacers. So I think just keeping that open mind and feeling, what's going to be right for each individual child. It might not be the same answer for everybody, but that's going to maximize their ability to get back to the activities and to the life that they deserve to have.
From far away, Coffee, just what is your dream?
There you go.
Well, yeah, I mean, for the two of them actually said everything that I would say, but for the most part, I think that with the AFM case, the anxiety kind of holds them back a lot, and we need to figure out a way to curb the anxiety as much as we wanted them to try new things.
Thank you, Coffee. Courtney?
I would just agree with what everyone else is saying, kind of just helping these kids be as independent as possible and doing the fun, typical kid things that they should be doing and that they should enjoy as much as we can.
Great. Mahim?
Great, yeah, and I would echo what's been said about quality of life being the ultimate outcome that we're trying to maximize. From my bone perspective, though, that sort of translates to fracture prevention. What we want is to prevent fractures, as that can derail the progress that our patients are making when it comes to the physical therapies and other activities that they are doing.
So, Sarah, you already accomplished a lot of dreams, but what is your next dream?
For my dream for AFM is I really want there to be more awareness, because not very many people have heard of AFM. I do think it is amazing that so many more people have just in the last 6 years or so. But I would really love for there to be more awareness, because with more awareness comes more research. And AFM is totally not a typical STI at all. So I think it'd be nice for people to understand that people can still have an STI and be able to walk and things like that. So I really would like for awareness to be the next thing that happens.
Thank you very much. Christina, I will skip you because I want to ask the same question for later. But I will ask everybody to move back to the stage and get ready for the next series of lectures. And thank you so much. Be aware that we are behind by approximately 10 minutes, but we are going to keep going and we are going to accomplish our virtual symposium today. Thank you very much, and please move to the stage. Thank you.
Thank you.
Thank you all.
Thank you.